Hello, and welcome to your Science of Psychedelics class. I'm Dr. Bray. You can call me Brenna. This will be our first kind of mini introductory lecture. This is my first time teaching in an asynchronous course format, so please bear with me. I'm going to do a screen share. I have a little PowerPoint that we'll go through for our first mini lecture. So let me just quick turn that on here. Okay, fantastic. And then let me get this into presenter mode. Excellent. So once again, welcome to our Science of Psychedelics class. In this little mini lecture, I'm going to go through a little brief introduction of myself and an introduction that I'd like you to provide in the discussion section for some homework for this lecture. I'll talk a little bit about why research and science are important to me personally and why I'm involved in research science. We'll talk a little bit about recognizing humility in research and science, which I think is a very important piece that it's important for any student to understand about research or science and aligns quite well with contemplative practices. We'll talk a little bit about the scientific method and methods of contemplative inquiry, and then we'll talk again about kind of openness and humility in science. A little bit repetitive there. So, class introductions. I like to begin every kind of research or science-based class that I teach by asking and providing students some space to share a little bit about them, and then also a little bit about maybe kind of their research identity or some space to explore that. So, some questions that I would invite you to consider for yourselves and maybe include in the discussion. First of all, of course, any personal information that you'd like to share with me or the class about yourself. Where are you? What are you interested in? Things like that. Why are you taking this course? The more that I can know about you as students enables me to kind of better tailor the course to you. And this is an asynchronous course, so a large portion of it is set, but it's just always helpful for me to know really what your as students' objectives are. Any relevant course goals that you have, any kind of outcomes that you're hoping to get from this course. Maybe you want to use psychedelics in clinical practice or in research, kind of long term. Maybe you're just kind of generally interested, things of that nature. And then shifting gears away from psychedelics a little bit and focusing on that research and science piece. Really, what do you think of when you hear the word research or you hear the word science? For some people, that makes them very excited. For some people, the word research feels really boring to them. For some people, the word research can feel really intimidating to them, like this thing that they don't really have access to. I know that for a long time, research felt that way to me, and science often did as well. And then any research or science experiences that you have, familiarity, feelings, disinterests, any career goals, just broadly, doesn't need to be relevant to this class if you know. And then what types of things are you interested in? I started asking this of all my students when I started teaching a research and program evaluation course in the clinical mental health counseling master's program at Naropa. That research course is a required course. It's required for CACREP accreditation for the master's program. So I heard from professors who had taught the course before that students maybe weren't particularly interested in research, or maybe they were very intimidated by research, and there was a large variety in the feelings that students had around research. So I started with this activity so that I could kind of get to know where my students were at. And I find that it can be very helpful in most research and science courses. So with that, I'll share with you a little bit of myself, how I would answer those questions and why research is so important to me. So I have a PhD in biomedical science and neuroscience that I got in 2018 from the University of South Dakota. My graduate work was focusing on the neurobiological underpinnings of stress-induced relapse, essentially. So we were looking at the ability of stress hormones like cortisol in humans to cross the blood-brain barrier, which they can and do, and act in central tissues in the brain. that's already a well-established fact. Before I started getting into research, we really focused on a part of the brain that had very high expression of stress hormone receptors, which is called the ventral hippocampus. Most people know the hippocampus from the Judge Kavanaugh trials. The dorsal hippocampus, the upper part, is related to memory and navigation. The ventral part, the kind of underbelly part, is highly related to regulating stress responses. So when we get stressed out, our body secretes hormones. They can cross the blood-brain barrier, act on central tissues in the brain, which they can and do. And that can have a variety of downstream impacts that can impact our reward salience, that can impact our ability to regulate our stress system, that can have kind of anxiety impacts. My work really focused on and identified a connection that exists between that part of the brain, the hippocampus, and the nucleus accumbens, which is a brain region that we most commonly associate with reward responses and reward salience or reward value. So just to kind of wrap that up, what we found was that in healthy individuals, we were working in a preclinical rodent model of amphetamine pretreatment and withdrawal. So in rats who had never been exposed to amphetamine, when we infused a stress-relevant dose of corticosterone, which is kind of the cortisol equivalent for rodents, into that part of the brain, the hippocampus, we saw these very robust increases in dopamine in the nucleus accumbens, which is a very positive, healthy, normal stress coping response, right? And most people kind of scratch their heads at that. Stress tends to have a bad rap. We don't like stress. It doesn't feel comfortable. But stress actually has a lot of very important implications in the body. One is that it helps us focus and it gives us motivation to complete tasks. So the example that I give here is perfect for this class. You're a student. If I were to say right now, you have a, project that's 75% of your grade and it's due tomorrow, you'd feel very stressed out. Now, if I tell you you have a project that's 72% of your grade and it's due the second to last week of class, you're not going to get so stressed out about that, right? You're going to just kind of go about your day. And then as that deadline gets closer and closer, you're going to start to feel a little bit more stressed out about that project. And so your body's going to start secreting more stress hormones, more cortisol. That's going to act in your brain on your neurotransmitters in the hippocampus. And that's going to increase your dopamine levels in the nucleus accumbens. So what that's going to help you do is it's going to help increase the reward value of that final project. So it's going to cause you to prioritize that final project over other things that you might find rewarding, which is going to help you choose to study and prepare for that final project over, going out with your friends or, whatever else you might like to do with your free time. So it's a very normal, healthy stress coping response. In rats who had been exposed to amphetamine, so daily for 2 weeks and then put through withdrawal, so we were kind of mimicking a college student who might abuse Adderall or, Ritalin and then try to stop. In those rodents, when we infuse the same stress-relevant dose of corticosterone, cortisol, into the hippocampus, we actually saw their dopamine levels reduce in the nucleus accumbens. So this aligns with what we hear anecdotally in the research from humans who are going through amphetamine withdrawal when they've been abusing amphetamines, whether that's Adderall, Ritalin, or methamphetamine, and they try to stop. They'll usually say something like, the withdrawal process was hard, everything was okay, and then something stressful happened and I lost all motivation. And I needed to start taking again the amphetamine to kind of get the motivation to study or, to do whatever it was I need to do or to cope with the stress. So we see hypersensitivity to stress and anxiety as core central features of amphetamine withdrawal syndrome, which is a clinically diagnosable DSM-5 syndrome. So this finding that stress exposure in individuals in amphetamine withdrawal actually reduces dopamine output aligns with what we hear from users, that their stress systems are dysregulated such that when they are exposed to a stressor in that withdrawal period where they're very vulnerable to relapse, they actually lose motivation. So of course, then it would be logical for them to go back to using so they can get the motivation they need. So that was my graduate dissertation work. Once I got my PhD, I opted not to pursue a career in that field, mostly because that work had been animal research and that really doesn't align with my own ethics personally. So I stepped out of the field for a little bit. I worked in medical writing and then in regulatory writing for medical devices. And then I was invited by the NIH to apply for a postdoctoral position in the field of complementary and integrative health research. So I applied to that position. I was accepted and I got my postdoctoral training in complementary and integrative health research and really focusing on eating disorders, specifically binge eating disorder, and the neurobiological underpinnings that we see in binge eating disorder and other processes of addiction. So my graduate work was kind of really focusing on the neurobiological processes of addiction and withdrawal. And taking 5 steps back, I have a personal history of having an eating disorder that I found recovery through about 15 years ago, very gratefully through a 12-step program. For me, service was a really important part of my own recovery and as it remains. And so I started volunteering at treatment centers. This was back in about 2011, so we were in the DSM-4. At that time, binge eating disorder was not recognized as an autonomous DSM-5 or DSM-4 diagnosis. What I quickly learned that meant when I started volunteering was that folks who had binge eating disorder, one, they didn't get clinical validation for their experience. If they recognized that what was going on with them was an eating disorder, which 95% of folks who have binge eating disorder don't actually know that they have an eating disorder. But if they were able to overcome that barrier and recognize that there was some disordered eating or some psychopathology going on, if they were to talk about with their clinicians, usually their clinicians wouldn't recognize that that was going on. Equally important, that meant that they couldn't get insurance coverage for treatment. And that piece really didn't sit right with me. So as I went along in grad school and was studying, the neurobiology of addiction withdrawal, I became very interested in the research that was coming out on binge eating at that time, which was the phenomenon of binge eating. So I started graduate school in 2011 and graduated in 2018. Oh, sorry, I started graduate school in 2013, completed in 2018. So also in 2013, we saw publication of the DSM-5, the 5th edition of the Diagnostic Statistical Manual, in which binge eating disorder was recognized as a valid DSM-5 eating disorder diagnosis. So what that meant and now means is that if folks are able to recognize that they have this psychopathology, there's a pathway, clinicians can have education on it as well and help them get the help they need. It's still largely under-recognized diagnosis, but that's a start. This also means that now folks can get insurance coverage for treatment. And again, that tends to be grossly insufficient, but it's a fantastic start. This also means that we now have an avenue in research to get funding for binge eating disorder. Prior to the DSM-5, it was very difficult to get funding for the phenomenon of binge eating disorder because it wasn't recognized clinically as a autonomous diagnosis, right? So in the field, there was still kind of this lack of consensus of like, we don't really know if this is a thing. Maybe it is, maybe it isn't, right? So once we got that diagnostic validation, that makes it now easier to get funding for research so that we can better understand and learn about this phenomenon, learn what's going on, and explore how we can best treat it. So that's a little bit of, for me, I'm extremely passionate about research. I think that it's a really important way that we can try to know things, a way of knowing or a way of thinking that we can know. And I think that it can be very, very important in policy change. To me, it's a way to enact change from within the system, playing by the rules, if you will. And that's kind of what I've dedicated my life to. So in my postdoc, I explored the neurobiological underpinnings of binge eating disorder that tend to overlap with addiction and withdrawal processes. My first study identified experts in the field of binge eating disorder, so researchers, clinicians, healthcare administrators, based on the number of PubMed publications they have, their, leadership positions in different leadership societies, NIH federal funding, grant funding, things like this. And so we identified about 45 experts, 14 consented to do 2-hour-long semi-structured interviews with myself that were anonymously recorded, and then we analyzed that data for themes. The first theme that came out of that data, I would never have, the first kind of major theme, I really would never have anticipated. So the kind of main theme that most experts talked about were environmental factors that pertain to binge eating disorder, and these were largely social justice issues. So these were things like invalidation, marginalization, systemic issues, systems of oppression was a really big one, discrimination, stigma and its psychological impacts. So really stigmatization around, maybe having a non-normative body weight shape size or a divergent body weight shape size, or having an eating disorder diagnosis or a mental health disorder diagnosis, as well as food insecurity, nutrition scarcity, economic precarity, interpersonal relation difficulties, and then predatory food practices, which is actually the only theme of those environmental factors that I thought that I kind of anticipated before conducting this study. We also have data now showing that about 95% of folks who have binge eating disorder never receive a formal diagnosis. 95% don't know that they have binge eating disorder. About 85%, 65 to 70% never pursue or access treatment, and about 85% lack access to healthcare. So this kind of highlights another major issue that I see in my field, and that we see more broadly in research. Prior to COVID-19, we have this issue where most research tends to pull from clinical treatment-seeking populations, because that's kind of an easy way to recruit participants for research studies. So with binge eating disorder, we have this issue where, first of all, just broadly in the field, we have this very kind of anorexocentric way of thinking about eating disorders. So kind of first there was anorexia. Then in the 80s, in tandem with processed foods hitting the market, we began to see patients showing up and talking about, binge eating and vomiting, bulimia nervosa. And so then research kind of responded to that to learn about bulimia. And it was generally viewed as being like anorexia, but almost like failed anorexia. Like these individuals want to be restricting their food, like what we think we know about anorexia, but they're not able to do so. Their biology overrides and they purge. We have a lot of data now showing that's actually not at all the case. But that was kind of how it was viewed initially. And then, in the kind of later 80s, 90s, and kind of 2000s, when binge eating disorder, when patients started reporting binge eating and having psychopathology about that, again, binge eating disorder was thought to be like bulimia, but failed, so it was thought these folks also want to restrict their food, but they're not able to, their biology overrides, so they binge and then they don't purge. And again, we have a lot of data now showing that that's not the case. We also have this issue in the field that we call the swag stereotype. That's an old, outdated misconception that ascribes all eating disorders primarily to skinny, white, affluent young women or girls, so swag. It is true that demographic tends to saturate treatment-seeking populations, both for eating disorders and for mental health issues and for health issues more broadly. It tends to be younger, affluent white women who really use the Western medical healthcare system the most. So it would make sense then that demographic would tend to saturate treatment-seeking populations for eating disorders. So we have this issue, where the research that we're conducting and getting on eating disorders tends to be from these treatment-seeking samples that tend to be saturated by thin, young, white, affluent women. With binge eating disorder, one of the benefits of COVID-19 was that it kind of put a firewall between treatment centers and research. So on the research side of things, we had to start getting creative about how we were going to identify and recruit participants for our research, and what types of research we were going to do. We saw a lot more qualitative research emerge during the pandemic, just because there was this kind of firewall from treatment centers. So and then we saw recruitment-wise, we saw a lot more inclusive recruitment measurements. So research looking at prevalence rates from national samples, things like this. And kind of collectively, we started hearing more the experience of folks with binge eating disorder. And the data that we have now tells us that binge eating disorder is not a white, young, wealthy women issue. So folks who identify as being members of the BIPOC or LGBTQ2+ community have 2 or 3-fold, respectively, higher risk and prevalence rates of developing binge eating disorder than their white, heterosexual, cisgendered counterparts. We also have data now coming out of food pantries in San Antonio, Texas, 2 different food pantries in San Antonio, Texas, and two international countries, and I can't remember off the top of my head which ones, that show us that about 65% of folks who use food pantries qualify diagnostically as having binge eating disorder. And what they'll typically say is, yeah, of course I binge eat. I binge eat the first 2 weeks of the month when there's food in the house, and then the last 2 weeks of the month, there's no food in the house, so it sets up this cycle kind of forced or involuntary food restriction and then binge eating. And what these studies also show is that this 65% of folks who meet this diagnostic criteria for having an eating disorder, it's primarily binge eating disorder, they'll usually report going about 7 hours or more without eating or trying to restrict the amount that they eat, or both. We see that this significantly correlates with weight and BMI. So when they engage in these behaviors, their weight and BMI go up. It also significantly correlates with eating disorder pathology. So when they engage in these behaviors, the psychopathology of the eating disorder goes up. My suspicion is that as they're trying to restrict their food, their weight goes up, and then they experience a stigmatization that most folks do who live in larger bodies in our culture, and then they start to develop the psychopathology as a response to the trauma response, really, to the stigmatization and adversity that brings. When asked why these folks are trying to minimize or restrict their food, what they will say are, one, their allotment is insufficient, right? So food stamps are insufficient, so they're trying to stretch their food to make it last. 2, they're trying to restrict their food so that they can allocate it to other family members. So this would be like a mother who's trying to eat less so that her kiddos can have more. And 3, prioritizing their food allotment for toiletries. So this would be things like tampons or diapers, rather than food. So this data that we have really has enabled us to have a greater understanding of what binge eating disorder really is, right? And what we tend to see in binge eating disorder is that the current standard of care, which tends to be eating disorder focused cognitive behavioral therapy, as outlined by Chris Fairburn, tends to have about 30% success rates in binge eating disorder, which is pretty low. And from this perspective, with this emerging data that we have, that kind of makes sense, right? If you're a mother and you're trying to eat less so that your children can have more, and that prompts you to binge eat, using a workbook that tells you to just love your body and be satisfied with how your body looks is not going to be particularly effective, because that's not really what the problem is. So that's a very long-winded 15-minute introduction to myself. Why I really love research and I'm so passionate about research and science. I think it can be a very useful tool to help identify the truth and to help communicate the truth. In the psychedelic space, I'll just do one more little diatribe. So when I started teaching last year, I don't know how long this recording will stay up. So when I started teaching in 2024, in the clinical mental health counseling master's program at Naropa, I was teaching research, so primarily kind of like statistics, program evaluation. And as I mentioned, I had heard from previous professors that a lot of the students weren't particularly interested in research. So I began, as I've just done with you, by asking, how do you feel about research and what are you interested in? And what I really quickly learned was that a lot of my students were very interested in psychedelics. So I really started pulling in research on psychedelics into the class in order to kind of help, facilitate their engagement in the content and the materials. Um, for me, so that's kind of how I really started getting into the research space, but I actually became aware of psychedelics much, much earlier than that. So ketamine, which most folks are familiar with, when I was in grad school back in 2013, ketamine was very commonly used as an anesthetic in most preclinical, so animal research models. And because I was a stress researcher and I was really, engaged in neurobiological processes of depression, anxiety, addiction, withdrawal, things like this, I always found it really baffling that ketamine would be used as an anesthetic in rodent research, especially in rodent research that was looking at depression. And I would always kind of call out, like, well, that's a very big underlying variable because we also know that ketamine on its own facilitates new brain cell connections, which we know reduces depression, and now, of course, we have all this data showing that ketamine is a very strong antidepressant in some contexts. So I just became, that was kind of my first introduction to psychedelics, was learning about ketamine, and I was very fascinated by how it works. It's a gas, which in the brain, which means that at a molecular level, it can cross cell membranes, whereas more typical neurotransmitters can't do that. So I thought that was pretty interesting. I thought that its ability to facilitate what's called long-term potentiation, so the development of new connections between brain cells, was really, really just interesting to me, innovative, novel, and potentially impactful. I continue to believe that's the case, but what a lot of people overlook is that if ketamine isn't administered with a protocol, then you also risk just strengthening connections, creating more connections between pathways that are already there, right? So if you have a patient with depression and you administer ketamine and you don't have a protocol around that, you risk actually worsening the depression and really like strengthening it at a neurobiological level. And we'll get into that later in the class, but that's just like something that gets me really excited about ketamine. And then in graduate school, I was doing rat brain surgeries for most of my time in graduate school, the last 2 to 3 years of graduate school. And unfortunately, I had several, if not many, rats actually die on the stereotax, either while during surgery or after surgery. One benefit of that, and I will add that animal research is a very sensitive subject, I know, especially for many folks at Naropa. So I try to, avoid it if I can. But what I learned from that was that when a living being dies, they have what's called blebbing of all of their brain cells. So essentially, if you think of every brain cell as like a water balloon, we've got all these little water balloons in our brain. When we die, as we begin to lose our oxygen supply to the brain, our brain cells get strangled and eventually they bleb, which is the equivalent of like all the water balloons popping. And so they release all of the neurotransmitters they have into the brain. And I just kind of observed that, went on. And then at the end of graduate school, I had a cardiothoracic surgeon at NYU Langone reach out to me for some potential grant work. And they shared some observations that they had made during cardiothoracic surgery, in which they were really interested in these near-death experiences. And they said, every time we have a near-death experience where someone kind of dies during surgery and we have to bring them back to life, they kind of say the same thing. They talk about feeling this oneness with God. They talk about seeing a white light. And the first thing they say to a man or woman is, "Why did you bring me back?" And so when Sam Parnia is the physician's name, when Dr. Parnia shared this with me, I kind of thought about what I knew about primarily the serotonin system and what happens in the brain right before death. And, we have, when we talk about serotonin, and again, we'll get into this all much, much later. Serotonin has about 1 million different types of receptors in the brain. And one type of receptor that serotonin has, the 5-HT2A receptor. So 5-HT2A is the chemical abbreviation for serotonin. So it's the serotonin 2A receptor, has very, very low affinity for serotonin, meaning you need a lot of serotonin around for this receptor to get bound. It's almost like if you think of Velcro, you know, when Velcro is really weak and it doesn't really stick very well, so you need to like hit it with a lot of force. It's like that. So it's very low affinity for serotonin, meaning you need a lot of serotonin to be around for this receptor to get bound. And in fact, and then when this receptor is bound, it is associated with a lot of psychedelic properties, right? The 5-HT2A receptor is one that is pretty central to a lot of psychedelic actions. You hear people talking about a sense of connection to all things, a sense of a deity or kind of a spirituality, spiritual connection. Oftentimes there's auditory, or what clinically we would call auditory or hallucinatory, auditory or visual, sorry, hallucinations. And, you know, almost this kind of preparation for exodus from this life into, you know, whatever happens after death. And so going back to that one really core feature, that low affinity for serotonin, the only states that we know of that produce enough serotonin in the brain to activate this receptor are, one, if you ingest psychedelics that grow naturally on the earth and have been used through the ages by shamans to help prepare people for exodus from this life into the next one. And two, right before we die, when our cells bleb and then all of the serotonin, all of our cells are released, so we have a high enough concentration to activate these receptors. So to me, when I think about that, I think, gee, isn't it interesting that we have these cells we have these receptors in our brain. What I know about the brain and body in everything I've learned and everything I've seen is we don't have anything that is in our body just by chance. Everything has a function. The only thing I can think of that we don't know is, you know, the tailbone, which is thought to be vestigial, and maybe the appendix, but everything in the brain and body tends to have a function. So if we assume that these receptors aren't just randomly there, you know, that they actually have a function, what would that be? Well, the only function that we know of might be to help enact, you know, this sense of spirituality, this sense of connectedness, this preparation, this dissociation from this life, and this preparation to, you know, maybe go into another life. So these are kind of the facts and the information that I want to, and the curiosities and the excitement that I want to share with you in this class is just to kind of really facilitate, you know, why might it be that we have these receptors in our brain that do that? You know, what might that, if we think about that, and if we kind of learn about these receptors a little bit more, how might that inform what we think about psychedelics? If we go over to the example of ketamine, like I said too, ketamine can facilitate new brain cell connections. And it can also help facilitate the like take back of brain cell connections. So it can reorganize how brain cells are structured. And to me, again, I kind of think, well, isn't that interesting that we have this inherent mechanism in our brains that enable us to make brain connections and then make different brain connections, right? So it's almost like we have these processes built into our brains that are assuming we're going to make mistakes. They're assuming we're going to make some brain connections that we're going to need to take back, right? And we have processes in our brains that can do this. And then, you know, psychedelics can act on those. So I'm interested in the psychedelics. I'm more interested in why might it be that we have these processes in our bodies already, right? And those are really kind of the questions and discussions that I hope that we can facilitate in this class. So I'm going to do a quick stop screen share.